If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome, I'm Fernando, a GP in the UK. In today's episode, we're going to go through the NICE guideline on chronic heart failure, which was last updated in September 2025. Today's episode focuses on the drug management of the different subtypes of heart failure. If you haven't already, I recommend that you check the previous episode on heart failure diagnosis. The guidance on the remaining aspects of heart failure management will be covered in the next episode, so stay tuned. Right, let's jump into it. And as we have just said, today we're going to focus on the specific drug treatment for heart failure. Also, as we said in the previous episode, echocardiograms assess both systolic and diastolic function of the left ventricle. Categorizing cardiac function is crucial because the treatment of heart failure will be different depending on the ejection fraction. We classify heart failure as follows. Heart failure with reduced ejection fraction when the ejection fraction is 40% or below. Heart failure with mildly reduced ejection fraction when it is between 41 and 49%. And heart failure with preserved ejection fraction when it is 50% or higher. So let's have a look at the treatment of each of these subtypes. For people with heart failure with reduced ejection fraction, we will offer a combination of 4 medicines: an ACE inhibitor, a beta blocker, a mineralocorticoid receptor antagonist, and an SGLT2 inhibitor. For people who are on the maximum tolerated dose of each of these 4 medicines but continue to have symptoms of heart failure, we should consider switching the ACE inhibitor to an angiotensin receptor neprilysin inhibitor. What are angiotensin receptor neprilysin inhibitors? They are a relatively new class of medications used specifically in the treatment of heart failure with reduced ejection fraction. At present, the only available one is sacubitril/valsartan, which combines 2 mechanisms of action. Sacubitril, which inhibits neprilysin, an enzyme that breaks down beneficial natriuretic peptides. By blocking neprilysin, sacubitril helps with vasodilation, sodium excretion, and reduced cardiac remodeling. And then we have valsartan, an angiotensin II receptor blocker or ARB, which helps counteract the harmful effects of the renin-angiotensin-aldosterone system by reducing vasoconstriction, sodium retention, and aldosterone secretion. Together, the combination of sacubitril and valsartan improves cardiac function, reduces hospitalizations, and lowers mortality in patients with heart failure with reduced ejection fraction. Okay, let's go back to the general management of heart failure with reduced ejection fraction. And we need to note that if certain medicines are not tolerated, there are alternative treatment combinations that we should consider. For example, for people who have had angioedema after taking an ACE inhibitor, we will still offer a beta blocker, a mineralocorticoid receptor antagonist, and an SGLT2 inhibitor. And we should also consider an angiotensin receptor blocker or ARB instead of the ACE inhibitor. This is because the risk of angioedema is lower with ARBs than with ACE inhibitors, although it is not zero, so we should use caution and monitor the patient accordingly. An important safety add-on is that we should not use sacubitril/valsartan in anyone with a history of angioedema, as this is listed as a contraindication. People with heart failure with reduced ejection fraction who have symptoms of intolerance to ACE inhibitors other than angioedema should have a beta blocker, a mineralocorticoid receptor antagonist, an SGLT2 inhibitor, and sacubitril/valsartan. The initiation of sacubitril/valsartan should be guided by a heart failure specialist. Additionally, in people with heart failure with reduced ejection fraction, we should assess iron status and check for anemia using transferrin saturation, serum ferritin, and hemoglobin. For people with heart failure with reduced ejection fraction and hemoglobin less than 150 grams per liter, and iron deficiency, that is, a transferrin saturation less than 20% or serum ferritin less than 100, we should offer intravenous iron therapy. This is because trial evidence shows that IV iron improves symptoms and quality of life and reduces heart failure hospitalizations in several settings. especially in patients with symptomatic heart failure with reduced ejection fraction. If iron deficiency anemia is identified, we should not assume it is related to the person's heart failure, and we should consider investigating for alternative causes. There are other drugs that can be initiated in a specialist setting. I will not cover them in detail, but specialist treatment options include ivabradine, hydralazine in combination with a nitrate, and digoxin. Additionally, in heart failure with reduced ejection fraction, we should avoid verapamil, dalterazine, and short-acting dihydropyridine calcium channel blockers. The reason boils down to hemodynamics and outcomes. Verapamil and dalterazine are negative inotropes and slow AV conduction. In heart failure with reduced ejection fraction, that can worsen cardiac function and precipitate decompensation. Then short-acting dihydropyridines, like immediate-release nifedipine, cause rapid vasodilation and reflex tachycardia and hypotension, which has been linked to increased mortality. So it is considered unsafe in heart failure. For people with heart failure with mildly reduced ejection fraction, we should also consider treatment with the same 4 drugs as the reduced ejection fraction subtype. That is, an ACE inhibitor, a beta blocker, a mineralocorticoid receptor antagonist, and an SGLT2 inhibitor. For those who have symptoms of intolerance to ACE inhibitors, we should consider an ARB, a beta blocker, a mineralocorticoid receptor antagonist, and an SGLT2 inhibitor. But we need to note that an angiotensin receptor neprilysin inhibitor, that is, sacubitril valsartan, is not recommended in heart failure with mildly reduced ejection fraction. It is recommended only in heart failure with reduced ejection fraction. SGLT2 inhibitors, specifically recommended by NICE for heart failure with mildly reduced ejection fraction, are empagliflozin and dapagliflozin, for which we have specific NICE recommendations. Finally, for people with heart failure with preserved ejection fraction, ACE inhibitors and beta blockers are not specifically recommended, but we should consider a mineralocorticoid receptor antagonist and an SGLT2 inhibitor, again with specific guidance on empagliflozin and dapagliflozin as the preferred SGLT2 inhibitors in this subtype. When treating heart failure in people with chronic kidney disease, if the eGFR is 45 or less, we should consider using lower starting doses and smaller dose increments for the medicine combinations already mentioned. If a person's eGFR is below 30, the advice of a renal physician should be sought. So that is it, a review of the drug management of the different subtypes of heart failure. In the next episode, I will cover additional details and further management recommendations. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.